quick request before we begin. Please subscribe, like this episode, and tell us in the comments which community medicine topic you want next. It helps a ton. Welcome to episode 2 of Case-Based Scenarios on Child Survival. Today we focus on the R of GOBI-FFF, growth monitoring, oral rehydration, breastfeeding, immunization, plus female education, family spacing and food supplementation, specifically respiratory infections, and on vaccine-preventable diseases. Dr. Joshi, thanks for being here.
Delighted. We will anchor everything to India's integrated management of neonatal and childhood illness, spelled out as IMNCI, and to the Universal Immunization Program. So what you revise is exactly what you will write in exams and apply in clinics.
Scenario 1, a 6-month-old infant has an acute respiratory infection, ARI. Respiratory rate is 56 per minute. There is no chest indrawing and no danger signs. How do we classify under IMNCI, and what home-based care do we advise?
For age 2 months up to 12 months, fast breathing is 50 breaths per minute or more. At 56, this meets fast breathing. With no chest indrawing and no general danger signs, IMNCI classifies this as pneumonia, the yellow category. Justification is age-specific cutoff 50 and absence of severe signs. For management at home, start oral amoxicillin, standard outpatient first line. Typically 40 to 50 milligrams per kg per dose, twice daily for 5 days. Write weight-based dosing in your answer. Give careful fluid and feeding advice, continue breastfeeding, and teach the mother to use nasal clearance if blocked. Explain danger signs that need immediate return. Inability to drink, persistent vomiting, convulsions, lethargy, worsening breathing or chest indrawing. Arrange follow-up in 2 to 3 days to reassess the respiratory rate and work of breathing. Antibiotics are not indicated for no pneumonia, cough or cold, but here we do have fast breathing, so amoxicillin is appropriate. Pause and recall. What is the fast breathing cutoff for 12 months up to 5 years? Answer, 40 per minute.
Scenario 2, a 10-month-old has fever, respiratory distress, and excessive sleepiness. The mother reports refusal to feed for 1 day. On exam, you find chest indrawing and drowsiness. How do you classify, and what are the immediate steps and referral?
Chest indrawing plus a danger sign, drowsiness, poor feeding, meets severe pneumonia or very severe disease. Immediate actions at the primary facility: keep the airway patent, check oxygen saturation, and give oxygen if saturation is less than 90%. Give the first dose of intramuscular antibiotics before referral, ampicillin plus gentamicin as per weight, manage hypoglycemia if suspected, keep the child warm, and arrange urgent referral to the higher center with the referral note. These steps are straight from the IMNCI charts for 2 months to 5 years and pre-referral care guidance. Key tip: write pre-referral, IM ampicillin plus IM gentamicin, oxygen if SpO2 less than 90%, urgent referral.
Scenario 3, a 3-year-old has fever, cough, and coryza for 4 days. On day 4, a rash appears and spreads over the body. How do we approach diagnosis, including the clinical case definition, and what is community-level management?
The classic triad: fever, maculopapular rash, and one of the 3 C's, cough, coryza, or conjunctivitis, meets the clinical case definition for measles. WHO-aligned surveillance language that India uses: suspected measles is fever with generalized maculopapular rash and cough or coryza or conjunctivitis, or any illness a health worker suspects as measles. In practice, a 3-year-old with 4 days of fever and coryza, then a spreading rash, fits suspected measles. Diagnosis approach in the community: identify the suspected case, notify as per local surveillance, arrange for specimen collection for IgM if available, and line list contacts. Immediate management: give vitamin A. Age-appropriate therapeutic dosing for measles is 2 doses, 24 hours apart. For children older than 1 year, 200,000 international units each dose. Provide antibiotics, fluids, and counsel on nutrition. Isolate from susceptible contacts during the infectious period and look for complications: pneumonia, diarrhea, otitis. Community follow-through includes contact tracing and immunization checks in the neighborhood. Pause and reflect. Which single intervention reduces measles complications and mortality, most in low-resource settings? Answer: timely high-dose vitamin A therapy.
Scenario 4, an 11-month-old infant presents to the PHC completely unimmunized. What schedule will you advise now, and how do we catch up to 5 years?
Use the National Immunization Schedule under the Universal Immunization Program, then apply catch-up rules and maximum ages. At 11 months, that is today, BCG can be given up to 1 year, so give now. OPV, give now. OPV doses are provided in infancy and can be given up to 5 years at contact sessions. Pentavalent, DPT plus hepatitis B plus Haemophilus influenza type B, give dose 1 now, schedule dose 2 after a minimum 4-week interval and dose 3 after another 4-week interval, permitted up to 1 year of age. PCV, pneumococcal conjugate vaccine, start now as per state program, give per local schedule with a booster at 9 to 12 months if the series permits. RVV, rotavirus, can be given up to 1 year, start now if available per brand-specific age limits. MR, measles, rubella, first dose at 9 to 12 months, give now, plan the second dose at 16 to 24 months or the earliest opportunity thereafter, honoring minimum intervals. Vitamin A, give 1 lakh international units at 9 months with MR. For children older than 1 year, subsequent doses are 2 lakh international units every 6 months up to 5 years, 9 total prophylactic doses. Catch up to 5 years, write this sequentially in exams. Ensure all MR doses are complete. If the child missed the 9 to 12 months dose, MR can be given up to 5 years. The second dose at 16 to 24 months or the earliest opportunity thereafter, honoring minimum intervals. OPV can be administered at sessions up to 5 years, document each dose. DPT boosters give at 16 to 24 months and again at 5 to 6 years if age eligible when they present after completing the primary series. PCV booster at 9 to 12 months if the primary series was initiated, follow state guidance for late starters. JE in eligible endemic districts per local schedule. Continue vitamin A prophylaxis to complete 9 doses by 5 years. Document everything on the mother-child protection card and counsel for return dates. Pause and recall. Which vaccines can still be initiated at 11 months? BCG until 1 year, pentavalent, OPV, PCV, RVV brand-dependent upper age, and MR first dose.
Dr. Joshi, could you summarize the respiratory assessment ladder for exam answers?
Sure, start with danger signs, unable to drink, convulsions, lethargy. Then look for chest and drawing, count respiratory rate against age cutoffs, 50 for 2 to 12 months, 40 for 12 months to 5 years, and check oxygen saturation. Classify as no pneumonia, cough or cold, then home care, no antibiotics. 2. Or pneumonia, fast breathing more chest and drawing without danger signs and SpO2 at least 90%, then oral amoxicillin, feeding advice, follow-up, or severe pneumonia, or very severe disease, any danger sign, SpO2 less than 90%, or marked distress, then oxygen, first dose must intramuscular antibiotics, and urgent referral.
Before we close, a 10-second measles checklist for theory papers?
Write clinical case definition, fever, maculopapular rash, and cough, coryza or conjunctivitis. Notify, vitamin A therapy 2 doses 24 hours apart, supportive care, immunization check and MR coverage of contacts, and community surveillance for more fever rash cases.
Great. Today we classified ARI using IMNCI signs, practiced pre-referral steps for severe disease, diagnosed measles from a classic viral story, and built a practical catch-up plan at the PHC. Dr. Joshi, thank you for the crisp exam-ready guidance.
My pleasure. Revise the IMNCI 2023 modules and the National Immunization Schedule tables. They are high yield for both exams and clinics.
If this helped, do not forget to subscribe, like, and comment with your next requested topic. See you next time.